everybody to keep their mics on mute. I think that's important. Good afternoon and welcome everybody. Can I request everybody to keep their mics on mute, please? Brigadier Tathagat Chatterjee and Colonel S. Venkatesan for doing this at actually a very short notice. Really, thank you so much for taking your time and be willing to do this. So there are a few housekeeping rules that are put up over there. We request everybody to mute their microphones, to keep the background noise as minimum. Questions and answers will be taken at the end, but it will be only through the chat box. So please put your question in the chat box. I think if you can't hear audio, we suggest that you log out and log in again. Okay, so without much further ado, we're going to hand it over to Brigadier Tathagat Chatterjee and his team to take us through the overview of cytomorphology and hematological malignancy.
So you can start sharing your screen.
Dr. Tathagat, you can start sharing your screen. Is he muted, Manju?
Yeah, he's muted. Sir, you need.
Dr. Tathagata, you're muted. Your mic is muted.
Now you can hear me?
Yeah, we can hear you clearly. If you could share your screen and you're ready to go.
Is okay? Is it okay?
Yeah, we can just see it. If you can go to slideshow mode, then you are ready to go.
You ready?
Please go ahead.
So thank you, Professor Vikram and Professor Manju, for inviting both of us. I am Brigadier Tathagat Chatterjee. I am heading the Department of Lab Sciences and Molecular Medicine in Army Hospital Arana, which is the apex hospital of the armed forces, as most of you know. Professor of Hematopathology and Pathology at this apex hospital. So we are the opening batsmen of this HCC or Hematology Cancer Consortium, as I understand. So it reminds me of the days of cricket when Sunil Gavaskar and Chetan Chauhan used to open the batting. So that's it. So we'll open the batting for you and we will overview the cytomorphology in hematological malignancies. So basically the plan is simple. We'll introduce you to the morphology and I shall delve a few slides on the pattern diagnosis patterns in neoplastic hematopathology. We always go by patterns, and what I mean by patterns, I shall explain to you in the next few slides. And with this pattern, I'll tell you how we approach the peripheral smear and how we approach the bone marrow, whether it is the bone marrow aspirate and the biopsy. So the key word here is pattern diagnosis. And after we explain to you how we approach the pattern, we shall give you some case-based discussion, what we call the slide seminars. And I shall be delving on a few more cases where I shall tell you why the morphology helped us beautifully in coming into the final diagnosis. So I shall discuss two cases of acute lymphoblastic leukemia, one that was and one that wasn't. We'll discuss a case of PNET that wasn't actually a PNET. We'll discuss two cases of proptosis and the masquerading malignancy behind it. And of course, I'll end my show with a few cases of lymphomas which we diagnosed from the bone marrow where the treatment was started upfront instead of wasting time for the nodal histopathology. Of course, nodal histopathology is a must in the diagnosis of lymphoma, but these were some cases where we started treatment upfront after giving the diagnosis of bone marrow. So the morphology really helped us. So the careful assessment of the blood elements is often the first step in assessment of the hematological function and diagnosis. There's no doubt on this. So we examine the blood smear, which is the most important aspect in hematopathology. It yields important diagnostic information. It allows broad differentiation of diagnostic impressions. We form a lot of diagnostic impressions on the peripheral smear, and that will help us further in ordering further tests, whether it is cytochemistry or flow cytometry. we will not delve much into cyto and flow cytometry because we will be dealing entirely on the morphology of this. So this is, without much ado, this is how a peripheral blood smear looks like. Sounds basic to most of you, but then this is what hematopathology is all about. We start from the peripheral blood smear, and often it yields majority of the information. So we see the RBC morphology, and there are a lot of things to be seen in RBC morphology besides the anemia part. Various types of cells gives us a clue to what we are going to see further in the bone marrow. So when we talk of peripheral blood patterns in the peripheral blood smear, we talk of various patterns. We may have a neutrophilia pattern. Now, you know, neutrophilia is commonly seen in infections and inflammatory states. It is true. But you also know that neutrophilia can also be seen in the third trimester of pregnancy. It can be seen on patients on corticosteroids, whether you have used your growth factor to mobilize the stem cells. But neutrophilia is also a lurking feature in myeloproliferative neoplasm, particularly in chronic myeloid leukemia, which is being treated by hydroxyurea. So you see the classical neutrophilia with hypersegmented neutrophil, hypersegmented neutrophils, and you know that you're dealing with a CML which is undergoing treatment. So neutrophilia can give you a lot of patterns, and neutrophilia does not just mean infection, inflammation. Lurking malignancies can have a neutrophilia pattern. Similarly, the leukoerythroblastic pattern. Now, this is, circulating nucleated RBCs along with myeloid precursors. Now, myeloid precursors can be myelocytes, metamyelocytes, it could be blasts, it could be promyelocytes. Along with circulating nucleated RBCs in the peripheral smear gives you a lot of information. And with that, if you see the hyperchromic or hypochromic teardrop cells, it adds further on to what you're going to expect further in the bone marrow aspiration. So hematological malignancies, metastatic carcinomas, granulomatous, radiation effects, extramedullary hematopoiesis, all these can cause leukoerythroblastic blood pictures. Then you have the abnormal mononuclear pattern. Now, the abnormal mononuclear pattern could be a classical blast. So it could be an AML M4 or AML M5, as used to call it in the FAB criteria. And when you're talking about AML M4 and M5, the differential diagnosis of APML, acute promyelocytic leukemia, particularly the hypogranular variant, comes immediately to your mind. And you have to formulate an immediate diagnosis because the treatment is based on what you are saying on the morphology. And the clinicians are going to immediately start a particular type of treatment, which some of you are aware of in APML. So the abnormal mononuclear pattern is a very important step in the peripheral blood smear. You can have the reactive downy cells. The downy cells mimic, promyelocytes and myelocytes and blasts. So downy cells are seen in infectious mononucleosis. So here in peripheral blood smear, if you're seeing downy cells and you think it is leukemia and vice versa, then it is a huge embarrassment. And finally, the patient does not benefit. So you have to be very clear about your morphology. The hairy cell leukemias also come in the abnormal mononuclear pattern. The Burkitt's leukemia lymphoma syndrome, that is the L3 pattern, does come in the abnormal mononuclear pattern, and it has got a very, very characteristic feature based on which we can immediately give a diagnosis on the peripheral smear. The flower cells, the floret cells, these are seen in adult T-cell leukemia lymphoma syndrome. So these are very classical cells which we see in the abnormal mononuclear pattern. The Sézary cells, the cerebriform cells, the mast cells, so many features come in the abnormal mononuclear pattern. So we have to be very, very meticulous when we see peripheral blood smear. The erythrocytosis patterns, which you see in polycythemia vera, is another important pattern. Now, the thrombocytosis pattern, you got a lot of platelets in clumps in the peripheral smear. Are you dealing with MDS with thrombocytosis? Are you dealing with myeloproliferative neoplasm? Are you dealing with ET, or are you dealing with the reactive cause, which is causing a lot of platelets in the peripheral blood? So all these features are very important for you to know. The eosinophilia pattern, simply allergic conditions, yes, we are all aware of it. But what of NHL? What about of hypereosinophilic syndrome? What about Sézary syndrome? They all have a eosinophilia pattern. Similarly, the monocytosis patterns of chronic myelomonocytic leukemia, SLE, rheumatoid arthritis, and AML are very important for you to know. The bicytopenia and the pancytopenia pattern in the peripheral blood smear gives you an indication whether you're going to get a bone marrow infiltration syndrome, where you're dealing with a TTP-HUS syndrome or a multiple myeloma. Similarly, the leukemoid pattern can be seen both in MDS as well as in chronic neutrophilic leukemia. And when you see leukopenia, are you dealing with a hypocellular leukemia? Are you dealing with the aplastic anemia? So all these pictures are there in the peripheral blood. So the pattern diagnosis helps you to establish some sort of differential diagnosis which comes into your mind. Then we go to the bone marrow. The diagnosis and management of many such hematological diseases depends on the examinations of the bone marrow. It usually involves two separate but interrelated specimens, the aspirate and the biopsy, both of which are equally important. So these are a few cartoons which show the lovely hypercellular aspirate you see in aspirate and the bone marrow biopsy, which is on the right side of the picture. What are the patterns you expect in bone marrow? The aspirate can be normocellular. A normocellular pattern can be in anemia of chronic disease, in hemophagocytic lymphohistiocytosis, in myeloproliferative neoplasms, in megakaryocytic hypoplasia, MDS, myeloproliferative neoplasms. All these can cause a normocellular pattern. So when you're dealing with MPN, you just don't think that it will be hypercellular. Even a normocellular pattern can give you a feature of MPN or an MDS. Now, when you see a hypercellular bone marrow, are you just dealing with the aplastic anemia? Are you dealing with the post-chemotherapy? Are you dealing with the post-transplant setting? Or are you actually dealing with a hypocellular leukemia or a hypoplastic MDS, which is quite common in a country? 30% of MDS are hypocellular MDS. So all these patterns comes in bone marrow. The erythroid preponderance pattern or the erythroid hyperplasia patterns, it can happen in hemolytic anemia, it can happen in AIDS, it can happen in myelodysplastic syndrome. The hypercellular and the myeloid preponderance also, there's another feature where you get MDS and you get MPN and various underconditions. The lymphocytosis, plasmacytosis pattern, CLL, PLL, lymphoplasmacytic lymphoma, Waldenstrom's, LGL, MGUS, all these can cause the lymphocytosis, plasmacytosis pattern. The mononuclear cell infiltration in the bone marrow biopsy, is it paratrabecular? Is it interstitial? Is it multifocal? Is it diffuse? All these can give you various clues. For example, paratrabecular pattern you can get in follicular lymphoma and vice versa. The megakaryocytic hyperplasia, you get a lot of megakaryocytic hyperplasia and myeloproliferative neoplasm. Is it polycythemia vera, in which the megakaryocytes are various sizes with cloudy appearance? Is it tight clusters of megakaryocytes with a normal cellular pattern? That is essential thrombocytosis. Is it extremely tight clusters with hypercellular pattern? Are you dealing with myelofibrosis, precellular phase? So the megakaryocytes can give you a lot of information. The dwarf megakaryocytes you see in CML. MDS with thrombocytosis can have a megakaryocytic hyperplasia, and the all familiar 5q minus syndrome where you have the hypolobotate megakaryocytes. All these can give you a lot of clue when you're dealing with the bone marrow. Then the bihyperplasia and the panhyperplasia pattern. Remember, acute panmyelosis is the type of AML where you have a panhyperplasia, you hardly see blast, and then when you suspect that, then you do a CD34 in the bone marrow biopsy and you reconfirm that it was a panhyperplasia of acute myeloid leukemia. The granuloma and the histiocytic patterns, as in AIDS, Gaucher's disease, Eldis bodies, tuberculosis, all these patterns are very, very important for us. So in short, when we see a peripheral blood and when we see a bone marrow, the patterns gives us a lot of clue in achieving a differential diagnosis based on which we do further tests, whether it is flow cytometry, immunohistochemistry, or cytochemistry. Ancillary techniques, as I already said, can be both in the peripheral blood smear and bone marrow aspirates along with immunohistochemistry. See, for example, cytochemistry on the left shows the MPO stain, which is so positive in various AML conditions. And on the right, you see the block positive of past stain, which you see in ALL. So all these will help you based on the pattern diagnosis, which you have achieved with a reasonable idea of what is the differential diagnosis. Now, having said that, the next part of my discussion is on case-based illustration where morphology played a very, very important role. So I must admit, yours is one of the most baffling cases. Let's see how baffling these cases are and how did morphology help us. So this is a 15-year-old girl who presented with complaints of mass per abdomen and loss of appetite of 2 weeks duration. Menstrual history, past history, and personal history were not contributory. And the mother had tuberculosis. That was the only family history we could get. So 15-year-old girl, mass abdomen with loss of appetite of 2 weeks duration. Now see how hematopathology and morphology helped us. So a 15 into 15 centimeter globular abdominopelvic mass was seen per abdomen, which was firm in consistency, mobile. And that's another very important thing for pathologists to note. You must always do ward rounds. You must see patients along with the JRs of medicines and surgery, and then come back and see the slides in morphology. It adds on to your expertise. Without seeing patients, you will not be a good pathologist, leave aside being a good physician. So the imaging showed an ultrasound with 2 well-defined solid masses, largest measuring about 20 into 15 centimeters, and you can see the arrow. And the CT scan thorax showed a well-defined solid cystic masses, largest 24 into 17 centimeter. There was ascites, there was pleural effusion, and there were evidence of retroperitoneal and mesenteric lymph nodes. The LDH was high, and this was very important for us to note when we came into the picture. They thought of a bilateral dysjeuvinoma. Now, how was a hematology or a hematology pathologist coming into a picture of bilateral dysjeuvinoma? So this was the peroperative finding, where a staging laparotomy was planned with fertility-sparing surgery of a right salpingo-oophorectomy and a right pelvic lymph node and para-aortic lymph node biopsy, and etc. We received this impression and scrape smear on cytology, and the surgical pathologist saw this, couldn't understand it, and called Professor Venkat, Professor Ankur, who was our professor of hematopathology earlier, and me onto the slide. And we saw this large atypical lymphoid cells, and it was certainly not the feature of dysjeuvinoma. We saw round cells singly dispersed with no definitive pattern. So here you have hematopathologies being requested by the surgical pathology in a frozen section to opine, and that couldn't have been better. We work under one roof in this department, RR, and we talk to each other and we discuss each other and look at this case. This was actually an acute lymphoblastic leukemia which had infiltrated both the ovaries, and people were thinking on the line of dysjeuvinoma. So a left ovarian mass resection was finally not carried out. We left it at that. We said nothing doing, stop the surgery. And this was the histopathology examination, where the ovarian tumor and the pelvic lymph node was completely effaced by diffuse infiltrate of large lymphoid cells, effacing the parent architecture. And we did a series of KI67, which was so highly positive. It was 100% with a TDT, which shows it was acute leukemia, and CD3 strongly positive. So it was a TALL, and these were the positive and the negative markers. And TALL was what it was and not dysjeuvinoma. So you see how the morphology helped us in achieving the diagnosis. Post-operative, hemoglobin started falling, the TLC started increasing, the peripheral smear now came to us, it started revealing blasts, and subsequently the bone marrow was done, which again revealed 90% lymphoid morphology blast, and TAL was confirmed with the MPO negative and a block positivity, as you've seen on the right side on the PAS stain. And these were the various immunophenotypes. We shall not go into detail. The immunophenotype showed the positivity for cytoplasmic CD3. So in summary, a 15-year-old girl presented with a bilateral adnexal mass, which was an abdominopelvic lump, who was suspected to have dysjeuvinoma, a germ cell tumor, underwent surgery. The hematopathologist was called in the scene when the intra-op impression was suggestive of a lymphoma. A diagnosis of a TALL with extra lymphatic manifestation in the ovaries was discussed. The treatment augmented BFM protocol was given, and patient is in remission. This was the peculiarity about the case: infiltration of leukemic cells to ovary mimicking a malignant ovarian tumor, and it was an unusual case because it was diagnosed by cytology by a hematopathologist, and that is the importance of morphology. My second case, a 3-year-old child, a leukemia that wasn't. A 3-year-old child presented with fever of 2 months history, not responding to antibiotics. He had swelling in the right cervical lymph node of 2 months duration, which was progressively increasing in size. He had splenomegaly of 2 months duration and had bilateral proptosis with dilated veins over the forehead and multiple scalp swelling for 3 days. Child was investigated with various blood tests. FNAC of the lymph node was reactive, and the diagnosis in the peripheral blood and the was acute lymphoblastic leukemia from a large hospital in the periphery. With this, the patient was referred to us for further management. We did the investigation. Hemoglobin was very low. It was 3.3 gram%. Various other tests were done. We saw the PBS and we saw a bicytopenia pattern with microcytosis and anisopoicosis, a lot of teardrop cells. And we saw very few atypical lymphocytes. We did a flow straight away on the peripheral blood smear, and we found that the LCA was negative. We knew what we were dealing with. We knew that we were not dealing with acute lymphoblastic leukemia. This was the radiology, where there were multiple lytic lesions and a broadening of the anterior mediastinal mass. This is how the bone marrow aspirate and biopsy looked us. And look at the arrow. These are small round blue cells with rosettes. And this was missed in the bone marrow by the large peripheral hospital, where they thought anything blue and anything small is lymphoblasts. That is not so. So you have to carefully look at these blasts, and you see these blast-like tumors are small blue round cell tumors with rosettes. We did an IHC on the bone marrow biopsy, and it was positive for neuron-specific anoles and synaptophysin, and it was negative for CD99 and myogenin. So we ruled out rhabdomyosarcoma, we ruled out Ewing's, and we came to the diagnosis of metastatic deposits of neuroblastoma. And how did we find out? We found small blue round cell tumors in rosettes, and that is where morphology helped us. We further did the flow cytometry, and the opinion was metastatic deposit of a CD56 positive tumor cells, likely neuroblastoma. And see the difference, what it was, an ALL, and the patient was sinking, and finally the diagnosis was a metastatic deposit of neuroblastoma. The FNAC cervical lymph node, which was suggested as reactive, was not reactive. They were all neuroblasts in rosettes, and this was actually the metastatic deposits of the FNAC of cervical lymph node. Again, here the hematopathologist was called to opine on this case. And this was a cervical lymph node biopsy, which differentiated into a metastatic neuroblastoma, Schwannian stroma poor neuroblastoma, as was the final diagnosis. Points to be emphasized, the neuroblastoma is a very close mimic to lymphoblastic lymphoma. The diagnostic dilemma, especially when bone marrow is involved, is important. Here I would like to acknowledge Professor Ankur Gupta, who was my colleague in this department. He just left this department 2 months back, and he was involved in the diagnosis of this case. And we published this in the American Society of Hematology, and we feel proud of the fact that we could help this patient in definitive treatment. Case 3. This is a 15-year-old female with history of fever and cervical swelling of 2 months duration with itching all over the body, had weight loss and drenching night sweats and splenomegaly. So it was under PU under evaluation. So they thought of Kala-Azar and they thought of a hematological malignancing. The standard differential diagnosis by a clinician, but look at the differential. Kala-Azar and hematological malignancy. I mean, how do you correlate the two? So you have to be very clear about your differential diagnosis. So this was the bone marrow aspirate, and it was a classical case of Hodgkin's lymphoma. So we diagnosed Hodgkin's lymphoma primarily from the bone marrow aspirate. Technically, you should not. There has to be a nodal diagnosis of Hodgkin's lymphoma. But in such cases, when the bone marrow has come to you, the bone marrow aspirate is showing the Reed-Sternberg-like cells in an appropriate inflammatory background, as you see in the bone marrow biopsy, you should go ahead. Let the node come to the surgical pathologist, but go ahead and diagnose this. And now you've got a lot of immunohistochemistry with you, and you can always do the CD15, the CD30, and the PAX-B, and suggest the diagnosis as Hodgkin's lymphoma. So we did this on the bone marrow biopsy. The treatment started upfront. Of course, the node came later on, and it was confirmed as a mixed cellular Hodgkin's lymphoma. So here, the hematopathologist, based on sheer morphology, has diagnosed Hodgkin's lymphoma on the bone marrow. And these are all the CD30 positive Reed-Sternberg cells. CD30 is 99% sensitive in all cases of Hodgkin's lymphoma. If a Hodgkin's lymphoma suspicion and CD30 is negative, then it is not Hodgkin's lymphoma. So this is the bone marrow involvement by Hodgkin's lymphoma. Remember, the bone marrow lacks lymphatics, so the infiltration in bone marrow is always a stage 4 disease. It is seen in 10% in classical Hodgkin's and mixed cellular, and 1% in lymphocyte predominant, and 3% in nodal sclerosis. We will not go into much of theory. Bone marrows are usually cellular, but sometimes it may be hypercellular. Necrosis may be seen post-therapy. Fibrosis is a very common finding and aids in the diagnosis. And when you diagnose bone marrow involvement by morphology in Hodgkin's lymphoma, it could be definitive, it could be highly suspicious, it could be suspicious. Definitive when the presence of Reed-Sternberg cells or a mononuclear variant in an appropriate cellular background, and where you have got a nodal diagnosis already with you. Highly suspicious, presence of atypical cells which are lacking the features of RS cells, but histologically proven disease in the node is there. And suspicious is when you have a foci of fibrosis in the absence of the Reed-Sternberg cell. However, the Hodgkin's disease has been diagnosed in the node elsewhere. So once you have a nodal diagnosis, and here you have a suspicious Reed-Sternberg cell in the focus of fibrosis, it becomes a stage 4 disease. That means Hodgkin's has involved the bone marrow. The penultimate case. Now, this is a beautiful place in Ireland, Enniskillen. This is where Dennis Parson Burkitt was born. He was a surgeon who was an epidemiologist and a surgical specialist who, around the Lake Victoria near Uganda, traced a huge belt of Burkitt's lymphoma. And this was his presentation in the International Journal of Surgeries of an unusual bone or mandible tumors. So remember, Burkitt was actually a surgical specialist. Here is a 4-year-old child who presented with a right jaw swelling with associated breathlessness and a right-sided pleural effusion. The peripheral blood examination was normal. The biopsy of the jaw lesion and the pleural fluid was sent for assessment. Now, the hematopathologist came in the picture in the pleural fluid. What did he see? He saw the pleural fluid cytology. The left panel shows a pleural fluid cytology revealing a highly cellular smear. The right panel shows the pleural fluid cytology with large lymphoid cells, with moderate amount of basophilic cytoplasm, with vacuolations, with nuclei, with open nuclear chromatin and inconspicuous nucleus. This is the classical Burkitt's lymphoma cell. And Professor Venkat, who is my next speaker, immediately took the pleural cytology, made a cell block, sent it for immunohistochemistry, and the rest of the pleural fluid, he did a flow. He knew he was dealing with Burkitt's lymphoma, and the flow showed a very bright CD45 positive, 19 positive, CD20 positive, and he knew absolutely sure with a kappa segmented restriction and a TDT negativity that he was dealing with Burkitt's lymphoma. So Professor Venkat took the pleural fluid, gave a diagnosis on the cytology, took it for flow, gave a diagnosis on the flow, made a cell block, put it for ISC, did a CD20 and a TDT, negated a CD20, and came into the diagnosis. In day one, we had given them a diagnosis of Burkitt's lymphoma based on morphology. And this subsequently came on later, the HP of the biopsy. This shows minimal cytoplasm, vesicular nucleus, and all those cells which you see in Burkitt's lymphoma. And these were some of the immunohistochemistry which we did, but the diagnosis was established and given to the clinicians much, much before. So the final diagnosis of Burkitt's lymphoma presenting as a pleural effusion, where the role of morphology was identification of the neoplastic cells as the cells of hematopoietic origin, and based on the morphological impression, subsequent use of ancillary techniques were done like flow and IC. The prompt diagnosis and treatment well before the availability of tissue diagnosis helped the clinician in treating this patient as a Burkitt lymphoma. This is AFMC. We have just celebrated the 58th year of our graduation, which started in 1962. Professor Venkat and Professor myself, we have been professors here and we have been trained here and we've taught here. So we thought two cases of proptosis, which were all thought of as inflammatory. And when we did the peripheral blood smear, and when we did the bone marrow, and when we did the flow cytometry, both on the bone marrow aspirate as well as the peripheral blood smear, we thought we were dealing with myeloid sarcoma. So these are the few patients we had and few cases of myeloid sarcoma where the clinicians thought it was a reactive condition. Similar two cases of pain abdomen weight loss and pain abdomen weight loss in two such patients presented with mesenteric lymphadenitis and mesenteric deposits. The hematopathologist was called in the picture when he saw the mesenteric lymph nodes and the mesenteric deposits, and he said, based on seeing a lot of myeloid-like blasts along with eosinophils and a few megakaryocytes here and there, he said this is myeloid sarcoma. So Professor Ankur, who was with us earlier, diagnosed this 4 cases of myeloid sarcoma. The WHO updated version defines it as a tumor mass comprising of myeloid blasts without maturation, and various AMLs like AML M2, M4, M5 are associated with AML. So the morphology is very important. You see sheets of blasts and you think you're dealing with lymphoma. You're seeing a lot of eosinophils along with the blasts. You're seeing a few megakaryocytes. You know this is something to do. When you see such slides in a deposits, like mesenteric deposits and all, you should recall the same picture had you seen a bone marrow, what would you have called? And then you'll get the answer. So the eosinophils, the megakaryocytes, along with sheets of blood, gives you a diagnosis of a myeloid sarcoma. And we could save all the 4 patients who were thought of as an infective pathology. So these are the common sites of myeloid sarcoma. And the cytogenic abnormality, generally in 50% of cases, you get cytogenic abnormality. So these were the few cases where I discussed with you. And before I switch over, I must emphasize that morphology is not a vanishing diagnostic technique with us. It is here to stay. And with morphology and with clinical correlation, the pathologist must go and see the patients in the ward and come back and see his slides. Morphology with clinical correlation forms the cornerstone of the diagnosis. I here now hand over to Professor Venkat to deal with further few cases.
Okay, good afternoon, everyone. I shall be continuing with the presentation. I must admit it was an excellent overview which is given by my HOD, Brigadier Chatterjee. And as you all agree with me, that was an excellent presentation, and my presentation may look pretty ordinary after his presentation. Anyway, I'll continue with the presentation. I'll be doing some of the other aspects of hematological malignancy, which was not covered in the earlier case-based illustrations. I shall be continuing with some more case-based illustrations. And the topics which I'll be covering is myelodysplastic syndrome, myelodysplastic MDS, MPN category, the chronic lymphoproliferative disorders, and I'll also do some morphological mimics, and I'll try to conclude at the end. I'll summarize the presentation. So moving on to the case 1. In this case, there was a 56-year-old female who presented with weakness. She also had anemia requiring transfusion. She received 10 transfusions in the last 1 year. Her initial CBC workup revealed pancytopenia. On examination, there was no lymphadenopathy or organomegaly. This was the bone marrow aspirate after doing a peripheral blood evaluation, which revealed only pancytopenia. As you can see, we have a bone marrow aspirate, which has got this marrow fragment, which is moderately cellular. Then after that, we looked at the individual cell series. The erythroid series was showing dyserythropoiesis in the form of megaloblastic change. The myeloid series, here you can see a neutrophil, which is hypolobated, it's showing just 2 lobes. The cytoplasm is hypogranular. When we see a hypolobated neutrophil with hypogranularity in the cytoplasm, we call them as pseudo-Pelger anomaly. Then in this slide, again, you can see another hypolobated neutrophil. We also saw some blasts in the background. So in addition, in the megakaryocyte series also, there was this megakaryopoiesis. The nuclear lobes have separated. Normally, we have a uninucleate, multilobated nucleus. Here we can see the nuclear lobes have separated, which is a sign of this megakaryopoiesis. So to summarize the bone marrow aspirate findings, we had a moderately cellular smear, which showed dysplasia in all 3 lineages. When we see dysplasia in 2 or more lineages, we call it as multilineage dysplasia. The bone marrow biopsy also confirmed the findings, whatever we saw in the bone marrow aspirate. In addition, we also saw these blasts in small clusters distributed away from the bony trabeculae, which we call it as abnormal localization of immature precursors or ALIPS. And the CD34 immunohistochemistry highlighted these blasts located away from the bony trabeculae. So when we see this abnormal localization of immature precursor ALIPS, we come to a diagnosis of myelodysplastic syndrome with excess blasts. On the bone marrow aspirate, we did a myelogram in which there was 10% blast in addition to the dysbiotic features. So putting all these features together, the bone marrow aspirate findings, the bone marrow biopsy findings, we arrived at diagnosis of myelodysplastic syndrome with excess blast 2. When we say excess blast 1 or 2, it denotes the percentage of blast in the peripheral blood in the bone marrow. Since the bone marrow had blasts ranging from 10 to 19, it comes into a subtype of myelodysplastic syndrome, namely the myelodysplastic syndrome with excess blast. Earlier in the 2008 classification, we used to name it as refractory anemia with excess blast 1 or 2. Now it has been renamed as myelodysplastic syndrome with excess blast 1 or 2. The percentage of blast is important, 1, because we could be dealing with a myelodysplastic syndrome with excess blast 1 or 2, or at times if the blast percentage is beyond 20% and beyond, we give a diagnosis of acute leukemia. And depending upon the subtype, whether we are dealing with AML or ALL, we will come to it later. So the relevance of the subtyping in this case of myelodysplastic syndrome is it affects both the survival as well as the incidence of evolution to acute myeloid leukemia. As brought out in this slide, 25% of cases of MDS EB1 and 33% of MDS EB patients with EB2, they progress to AML respectively, and the median survival for each individual subtype is different. The MDS EB1 having better median survival as compared to MDS EB2. So coming to the relevance of cytomorphology in this particular case, 1, we should be identifying the presence of dysplasia in multiple lineages, because those diseases with single lineage dysplasia and those diseases with multi-lineage dysplasia, they behave differently, they are prognostically different. Number 2, the identification of multi-lineage dysplasia is still, we have to make it, it's a morphological diagnosis. We have not graduated to flow cytometry routinely for making a diagnosis of myelodysplastic syndrome. The thing is, so we have to make a diagnosis on morphology, because only 50% of cases of MDS will be positive in cytogenetics. So remaining 50% of cases, you have to give a morphological diagnosis. The next important aspect is the diligent counting of blasts, because the percentage of blasts is going to predict the survival, predict the prognosis of the case, especially the MDS cases. So these were 2 important points as far as this case is concerned. Now we will move to the next case, which is similar to the previous case, but it is somewhat different from the previous case. Here we have an elderly male who presented to us with, it's a 52-year-old male, it's a middle-aged man who presented to us with a massive splenomegaly. And when we looked at the CBC, he had bicytopenia. You remember in the earlier case, the patient had pancytopenia. Here the individual has the bicytopenia, and there was an elevated total leukocyte count. Normally in MDS also we do not encounter splenomegaly. Here this patient had a massive splenomegaly. So after CBC, as a routine, we looked at the peripheral smear. In the peripheral smear, again, we saw some dysplastic features, the dysplastic polymorphonuclear cells, the neutrophils, which are hypolobated here. In addition to that, we also saw in the WBC series, there is increase in the number of monocytes, both percentage-wise as well as absolute count-wise, there was increase in the monocytes. And we looked at the RBCs. RBCs showed dysbiotic changes in the form of this presence of Cabot ring, which are nothing but the nuclear remnants, which is a feature of this erythropoiesis. In addition, there was also increase in the blasts in the peripheral blood, apart from the dysbiotic features and monocytosis. Here you can see a basophil in the peripheral smear. There was, these monocytes were active, they were eating away the RBCs, that is erythrophagocytosis. This bone marrow aspirate was subsequently followed by, this peripheral smear examination was subsequently followed by a bone marrow aspirate, where there was increase in the blast in the bone marrow aspirate. It was around 16% of the blast among all nucleated cells. Then when we got the bone marrow biopsy, we saw dysbiotic changes in the form of these small hypolobated dysplastic megakaryocytes distributed throughout the bone marrow biopsy. And we took help of immunohistochemistry, wherein we did for CD34 to get a rough assessment of the blast in the bone marrow biopsy, which is again increased in the bone marrow biopsy. So this was the salient peripheral blood finding was presence of dysbiosis in the myeloid series, in the erythroid series. There was monocytosis, there was thrombocytopenia. When you looked at the bone marrow aspirate, in addition to dysbiosis, there was 16% blast. Subsequently, we got the result of cytogenetics also, which revealed monosomy 7. And since the count was high, we also wanted to rule out CML, because at times CML can also have monocytosis when you especially have this 190 transcript. So we did that also, which came to be negative. So putting all these points together, there is presence of dysbiosis, the presence of increase in TLC, with increase in monocytosis, with increase in the percentage of blast in the bone marrow to 16%, we finally offered a diagnosis of chronic myelomonocytic leukemia 2. This is as per the latest WHO classification. Again, emphasizing the important aspects of morphology as far as this case is concerned. Here, one, we should be identifying the presence of dysbiosis, because presence of dysbiosis can lead to a diagnosis of MDS. But in addition, the absolute number of monocytes. Usually in MDS, we have less than 1,000 monocytes. Here in this case, we have a monocyte count of around 12,600. And the next important thing is blast enumeration. All these three things put together will aid in the formation of a diagnosis and further subclassification of the disease. Because the important aspect is, once again, here is a blast enumeration, because this blast enumeration is going to dictate the prognosis and the survival of the CMML patients, which is brought on as brought on this case. So these are two closely interrelated cases. Now we will move on to the case 3. This case 3 is another interesting case where we actually transferred a patient from a surgical ward to our side, because this patient, he's an elderly male who landed up in the surgical ward with history of non-healing ulcers. So he was in the surgical ward and he was being analyzed, he was being routinely evaluated, wherein there were multiple samples which were sent to one of the emergency lab we have in the hospital setup, where every day evening the sample used to go and the lab technician there used to send the sample saying that the sample is being repeatedly clotted. So they tried with EDTA, they tried with citrate for coagulation workup, and all the samples were getting clotted. So that's how we, myself and my HOD, when we were in FMC, we were brought into this case. And when we received the sample again, the sample was again clotted. So what we did is we called our lab technician and told him to put this sample at 37 degrees Celsius, thinking of some diagnosis at that time on our mind. The lab technician was also pretty baffled why the sahab was saying that put this clotted sample at 37 degrees Celsius. So I told him put it at 37 degrees Celsius, and after 20 minutes get the sample back to me, back to us. So to his surprise and to our relief as well, the sample became fluid after keeping the sample at 37 degrees Celsius. So we thought of cryoglobulinemia. So that's why we experimented with this, putting the sample back at 37 degrees Celsius. And after 20 minutes, the sample came to a fluid state. Then we were able to run a CBC, and we were able to give a CBC report to him after 2 days of admission to our hospital. So basically what we thought was cryoglobulinemia, because the whole sample clotted. If only the RBC portion was clotting, then we would have thought of cold agglutinin disease. We thought of cryoglobulinemia. The next time we collected the sample, pre-heated sample, pre-warm sample at 37 degrees Celsius. We got the sample, then we centrifuged it, we got the serum. And then after that, we kept it in refrigerator at 4 degrees Celsius. After 24 hours, we could see the cryoglobulin precipitate, which is a white precipitate, which you will see at the bottom of the tube. So that's how you diagnose cryoglobulinemia with the available facilities with you. So after making a CBC, then we went ahead with a peripheral blood smear, and the peripheral blood smear saw those findings which we expected actually. So we saw this rouleau formation of RBCs, where the RBCs are stacked like a pile of coins, one over the other in a linear fashion. So there was marked rouleau formation. In the background also, you can see some blue staining which is taken. This is what we call it as background staining. So whenever the globulin levels are high in the blood, the globulins also take up the stain which you're doing. So the background of the peripheral smear will also get stained. It's what we call it as background staining. In addition to this, we saw some cells which we expected to see. There is a lot of lymphocytes in the peripheral blood. In addition, there are some lymphoplasmacytoid cells or plasmacytoid lymphocytes, which is a kind of hybrid between lymphocyte and plasma cells. It's a cell which is in the transition phase from lymphocytes to plasma cells. And there was some increase in the plasma cells as well. This was on the right, the panel is the bone marrow aspirate, where we saw predominantly lymphocytes, and in addition, we saw some plasma cells. Then we did the bone marrow biopsy, and you can see this is a very beautiful picture of plasma cells. All these cells which we are seeing with the abundant pink cytoplasm are nothing but plasma cells which are ballooned up with the secretions, namely the immunoglobulins, which are stored in their cytoplasm, and it's in fact pushing the nucleus to the periphery. So all these cells with globulin inclusions, cytoplasmic inclusions, which call it as Russell bodies, are nothing but plasma cells. And in between, in the interstitium, there was admixed lymphocytes, which do not have that much of cytoplasm. They have a darker nuclei. So there was admixture of plasma cells and lymphocytes. Then we went ahead by doing immunohistochemistry. On the left, you have CD20 positive B lymphocytes. On the right, you have CD138 and 38 positive plasma cells. So there was equal distribution of lymphocytes and plasma cells. So we thought of lymphoplasmacytic lymphoma, and because the patient also had high amount of protein content in his blood, the serum protein was 12 with a globulin of 9 grams per deciliter. And so then we subsequently subjected him to serum protein electrophoresis and immunofixation. The result which came was M protein positive with IgM lambda, with IgM kappa light chain protein, IgM subtype. So with all these things put together, we arrived at a diagnosis of Waldenstrom's macroglobulinemia. The patient was subsequently managed with the rituximab-based regimen. In a month's time, his leg ulcers have vanished and his hemoglobin have improved. So this case, we published also that Waldenstrom's macroglobulinemia as an unusual cause for chronic non-healing ulcer. And when we searched the literature, there were few case reports as well where cryoglobulinemia they presented for the first time with an underlying malignancy. So the important lessons which we learned from this case is the presence of cryoglobulin as a cause of repeated sample clotting, as well as cause for a leg ulcer, and high degree of suspicion and timely intervention led to a better outcome in this case. Okay, next we'll go to some of the aspects where a pathologist gets baffled. So there are some morphological mimickers which I'll be showing you. So going to the case 4. Okay, so this was again a very beautiful picture which I'm showing you here. So this is very beautiful for a pathologist as far as a pathologist is concerned, where you have a cell with moderate amount of cytoplasm showing fine hairy projection. So whenever we get to see such cells, immediately the first thing which we think is of a hairy cell leukemia. So to confirm that, we went ahead with the flow cytometry, but in flow cytometry, what was baffling to us was almost all cells are falling in the progenitor region. Normally in hairy cell, cells are supposed to show a bright CD45 expression, and we will be having the cell cluster somewhere here. Here we find all these cells in the blast window. To add to our confusion, we also had another case the same day with the clinical diagnosis of hairy cell leukemia. So we were in a dilemma whether are we dealing with some mix-ups which has happened, because this case, the flow cytometry of this case revealed a classical pattern of acute leukemia, and it was negative for all hairy cell markers like 19, 11C, 103. So it was 90 negative, so it's not a BALL. So it was showing CD3 positivity and TDT positivity, confirming that it's a TALL. So what we did is we again called the patient. These two patients at two different dates. We repeated the procedure and we got the same result. So what we are actually dealing is with today was a case of TALL with fine hairy projections. So when we find such abnormal findings, which is very rare to see in literature, so what we do? We inform the entire world. So we published this case. So when we published this case, we also looked for some references to similar findings are seen by others also. And it was reported in some case of plasma cell leukemia and hepatosplenic gamma delta lymphoma that fine hairy projections were also seen and reported by some of our colleagues as well. So here, even though morphology has took us in one direction, the flow cytometry and the subsequent procedures took us in a different direction, giving a final diagnosis of TALL. So we published this case as TALL with unusual hairy projections. So this is one case which was baffling to us. So not all things are easier for a morphologist. We do get some sleepless nights because of such cases. So going to the next case, he was one of us, a retired doctor who underwent a procedure, cardiac procedure. Subsequently, he developed weakness, EC fatiguability. His hemogram revealed pancytopenia, and he was clinically examined. There was no organomegaly. Subsequently, he was subjected to bone marrow examination, which revealed a hypocellular bone marrow. So it was done in a previous hospital. So hypocellular marrow, pancytopenia, no organomegaly. So everything was fitting in with a picture of aplastic anemia. So somehow he was not happy with it, and he came to us for a second opinion. He couldn't get the previous slide, so we did a bone marrow again. The bone marrow aspirate was hemodiluted. The biopsy again showed a hypocellular marrow, but even among this hypocellular marrow, we could see some cells which are not looking like normal mature lymphocytes. They showed some clearing around them. So what we did is we went back to the bone marrow aspirate. We searched more diligently, and we found some cells which was looking like hairy cells. So we did a cytochemistry, that is TRAP, and these cells which showed TRAP positivity. The patient was not willing for another bone marrow for doing a flow cytometry. So, but this by the time a month had gone by, so when he came for the next review, his peripheral smear started showing more number of those hairy cells. It was around 9 to 10% of hairy cells. Then we subjected them to flow cytometry, and they showed all classical markers of flow cytometry. Thereby, we gave a diagnosis of hairy cell leukemia in this case. And after getting this diagnosis, he was treated with cladribine. The cytopenias have improved. He was symptomatically better. He became transfusion independent. The important aspect of this case is there are hairy cell leukemias who can present without splenomegaly, and this happens especially so when you have a hypocellular bone marrow. Again, we searched our cases in which we found around 4 cases in over the past 2 years where the case of hairy cell leukemia was diagnosed and there was no splenomegaly in those cases. So a careful observation of bone marrow biopsy, even if it's a hypocellular bone marrow, will yield a diagnosis, because as brought out by Brigadier Chatterjee, that the hypocellular bone marrow pattern can be aplastic, it can be hypoplastic MDS, hypoplastic acute leukemia, and rarely it could be hairy cell leukemia, where your morphological diagnosis, on morphology, if you pick up these cases, you can make a difference in diagnosis and outcome of these patients. So the last case is an 18-year-old male who's a resident of Bihar who came to us with fever, weakness, pallor, and left side abdomen pain. With this history, the classical history, if you give it to anybody, the first year resident would say it's going to be a Kala-Azar. But the patient had something else. He received 6 units of blood transfusion over the past 3 months. He had a pain in the left hypochondrium, probably due to splenomegaly. There was no significant past illnesses. On examination, there was no lymphadenopathy. He was febrile. He had massive hepatosplenomegaly. That was the only physical finding which we could get out of it. The bone marrow was done outside. The slides came to us for review. Outside was suggestive of acute leukemia. So we did a CBC which revealed pancytopenia. This was the photographs of the bone marrow aspirate, wherein you are seeing all those blast-like cells which showed multiple nucleoli, little cytoplasm, abundant vesicular nucleochromatin with multiple prominent nucleoli, thereby prompting us also to think in terms of acute leukemia. There was no slides available for cytochemistry, so we couldn't subtype it further. But when we looked at bone marrow biopsy, this is what was different from the routine acute leukemias which we see here. What we are seeing is the normal erythroid precursors, the myeloid precursors, and the megakaryocytes. And what we could see is these kind of immature cells which are there in between these normal hematopoiesis which is going on. And what is more important here is to see that this immature cells are lying within a space, and this space is lined by these flat-lined endothelial cells, which are nothing but the endothelial cells are sinusoids. So these cells were found within the sinusoids. So these cells are present basically within the sinusoids, and we did immunohistochemistry, which was negative for all immature markers. And what is positive is only CD3. And the CD3 again, once again, highlighted the presence of these cells within the sinusoid. So what we are dealing with is a neoplasm which has got characteristic intrasinusoidal distribution, and these cells are of T lineage. So with this clinical findings, the morphological findings of bone marrow biopsy, the immunohistochemistry, we gave a diagnosis of hepatosplenic T cell lymphoma, and which was subsequently confirmed on flow cytometry as hepatosplenic gamma delta T cell lymphoma. So what was important as far as this case is concerned is the identification of presence of these large cells with glass-like morphology, which mimicked initially like acute leukemia, but the bone marrow biopsy gave away the clue, the presence of these cells within the sinusoids, and they are of T cell lineages, and that's how we were able to arrive at a conclusion in these cases. As these cases do not fare that well, but somehow we arrived at a diagnosis based on these findings. So what we thought in this actually webinar is, instead of giving a didactic lecture, we thought we will share with you some case-based illustrations, so that if you could take at least 2 or 3 points from each cases, it would be a good learning exercise for you as well as for us. So to conclude, the evaluation of hematological malignancy doesn't stop until molecular studies in today's era. However, with the illustrations we had given, morphology still holds its ground, as it's often the guiding force for the sophisticated investigations to follow, like flow, molecular, and so on. Because especially when we are working in a resource limited setting, you cannot be doing flow cytometry and you cannot spend all antibodies with you. So you need to give some direction, which type of disorder are you looking at, so that we can narrow down, we can use our resources judiciously. And it is even more important in those cases where immunophenotyping may not yield a definitive diagnosis. So I think with this, yeah. So one thing is, last but not the least, is we would like to acknowledge the contributions which are given by Colonel Ankur Ahuja, who was part of our team till a month before he has moved to some other location due to our service requirements, and for sharing some of his valuable cases in this presentation.
Thank you. We have finished.
Okay. Manju?
Yeah, so we'll take questions from the chat box, and then maybe we can just have a discussion after that. So there is one question which is there in the chat box. This is from Dr. Neema Tiwari, that they had a young girl with fever off and on for 4 to 5 months and bruising. Bone marrow biopsy showed cells mimicking RS cells. However, there was no lymphadenopathy and minimal marrow fibrosis with these cells admixed with a reactive background. They did not have IHC facility available, so their question is how they should have gone ahead and done the further workup.
So in this case, to diagnose in a 3-year-old child as a primary bone marrow Hodgkin's lymphoma would be futile. So this has to be long-term follow-up. IHC is not there, so definitely this bone marrow biopsy must be subjected to IHC. We had one case of a child of 5 years with Hodgkin's lymphoma, but these are rarities. But however, if you have suspected, and if you have seen Reed-Sternberg-like cells in an appropriate background milieu in the bone marrow biopsy, then at least you should do an IHC. There are numerous mimickers of Hodgkin's lymphoma. Commonest is infectious mononucleosis, but infectious mononucleosis will come with fever and cervical and axillary lymphadenopathy. You have progressive transformation of germinal centers. They will also come with lymph node. They will not involve the bone marrow initially. So various mimickers of Hodgkin's lymphoma will be kept in mind. The child has to be put on long-term follow-up, and definitely the bone marrow biopsy, if you have suspected, should be sent to a center where the IHC facilities are available.
The next question is from Nikita. In multiple myeloma, what is the most common form of cellularity pattern in the marrow? And is bone marrow fibrosis common in multiple myeloma?
Yeah, in multiple myeloma, we do get bone marrow fibrosis. Maybe in around 10 to 20% of cases, we do get bone marrow fibrosis. The common pattern which we get in multiple myeloma is the diffuse pattern, but rarely you can get an interstitial pattern as well. And even a nodular pattern is also known to occur in multiple myeloma. The common pattern is the diffuse pattern.
Okay, I don't see any more question in the chat box. Vikram, you have anything?
Yeah. I just want to, thank you so much for those talks. I think while we tend to jump to flow cytometry and molecular, I think it's important not to forget and it's at our own peril to completely ignore morphology, because it often is very corroborative and correlative in making a diagnosis. Having said that, to both of you all, I mean, I just want to know, there's often this prognostic significance of myelodysplasia-related changes in AML. I mean, that can define by morphology, cytogenetics, etc. I mean, how would you put it to a student audience as the importance of this, and how do we go about diagnosing or classifying them in that particular subset?
Yeah, AML with myelodysplasia-related changes is one of the sub-classification of AML as per the WHO 2008 and subsequently 2016 as well. So we diagnose AML with myelodysplasia-related changes under three circumstances. Number one, if we know that a case is a known case of myelodysplastic syndrome and it has progressed to AML, then we can categorize them as AML with myelodysplasia-related changes. The next important thing is if this AML is associated with any particular cytogenetic abnormality which is known to occur with MDS, then also we can characterize them as AML with myelodysplasia-related changes. Where the morphology comes into play in AML myelodysplasia-related changes is that when you find dysplastic changes in multiple lineages, that is 2 or more lineages, and that too in more than 50% of the cells, if you are finding dyspoietic changes, then you can label them based only on the morphology as AML with myelodysplasia related changes. Normally, to say significant dyspoiesis as far as MDS is concerned, we take the cutoff as 10%. But whenever you want to say AML with myelodysplasia related changes, the cutoff has to be 50% of all the cells that should be showing dyspoiesis. So if it is AML with myelodysplasia related changes, then obviously the prognosis is not as good as those with other good risk groups.
And in addition to that, what Professor Venkat said, increase of promonocytes. Certainly you are seeing promonocytes increasing. They are as significant as blasts. So morphologically, if you see promonocytes, that's a sinister sign. Along with multilineage dysplasia in more than 50% of the cells, that again is a sinister sign.
Again, for a student audience, I'm just leading some questions over here. When you come to a variant hairy cell leukemia, is there anything, I mean, of course, the immunophenotype will help. Is there anything in the morphology that will kind of alert you that maybe we are looking at a variant?
Okay, so first thing is the TLC, the total leukocyte count, and the absolute lymphocyte count. When you see the classical hairy cell leukemia, you generally have a pancytopenia or a bicytopenia smear, and the lymphocyte counts are less. Vis-a-vis the atypical or the variant hairy cell leukemia, which earlier in your time and my time we used to call it as a family of a pro-lymphocytic leukemia actually. But now hairy cell leukemia variant is a completely new entity altogether. It generally presents with a very higher counts. The hairy cell morphology, the variants, the typical hairy cell around the cells may or may not be there. The monocyte count may not be suppressed as you see in the hairy cell leukemia. So these are various factors. So increase in the counts, not seeing the classical hairy-like projections as you see in hairy cell leukemia. And of course, the prognosis, of course, later on the treatment aspect, which you will say rightly, that not responding well to the conventional treatment. These are all the prognostic features which we see in a variant hairy cell leukemia. But as a morphologist, when you have very high counts and the lack of fibrosis in the bone marrow aspirate and the biopsy, when you see a biopsy, when you see fibrosis, reticular fibrosis grade 2 to 3, it is hairy cell classical. When you don't see this fibrosis in a way, that means your aspirate is easy to perform. Compared to a classical hairy cell leukemia, in a variant, the aspirate is easy to perform because the fibrosis is that much less. So these are all the telltale signs which tells us that you're dealing with the hairy cell variant.
Two more points is one, they may also show prominent nucleolus, which is not seen in a classical hairy cell leukemia, and they may be trap negative as well.
Right. Thank you.
There are two more questions on the chat. Nigita has asked, in multiple myeloma, is it a hypercellular or a normocellular or hypocellular marrow is more common?
Often it is hypercellular when it is a diffuse marrow involvement. When there is an interstitial involvement, you may have a normal cell marrow, but when there is a nodular infiltrate, you may have a hypocellular marrow also. But maybe around 80 to 90% of times it is going to be hypercellular.
And when you see this hypercellular marrow and you see syncytial sheets of hairy cells, which means coalition of more than 3 to 5 cytoplasms of cells, that is the surest sign that you're not dealing with a normal plasma cell. So the syncytial sheets of hairy cells in a hypercellular marrow clinches the diagnosis of a hairy cell leukemia. Of course, you can have interstitial, you can have nodular, but the diffuse pattern is the most prominent.
There is one more question from Dr. Neha, and she's asking in light chain amyloidosis if there is typical radiological feature of cardiac amyloid along with deranged FLC ratio, but there is no biopsy evidence. Can we make the diagnosis of cardiac amyloid? And she has further qualified it, saying that bone marrow biopsy has less than 10% plasma cells, I think, and fat biopsy is negative.
Yeah, can be.
It can be with a lambda restriction. We normally see lambda restrictions in amyloidosis vis-a-vis kappa restriction. So yeah, this is a very interesting question which needs a lot of research of cardiac amyloidosis. But definitely we can make a diagnosis in the absence of just about 10% cells. We can still make a diagnosis with a lambda restriction.
Okay. Vikram, you have anything? Otherwise, I think we have finished the time. So
Yeah, I think we are through with our time.
thank you so much, sir. Thank you, Dr. Tathagat. Thank you, Dr. Venkatesh. Thank you so much for coming up with such a nice presentation at such a short notice. Thank you so much. And we look.
Yeah, I remember interacting with you at AIIMS when you and I were doing DM.
Thank you, sir. Thank you. So we do have seminar again, the next webinar, which is discussing the immunophenotyping. We'll circulate the flyer to everyone. And the next webinar is on immunophenotyping in acute leukemias. And Dr. Prashant Tembure from ACTREC Tata Memorial Center will be giving that lecture. So see you again next time. That will be on 28th of August. Thank you so much.
Thank you, Professor Vikram and Manju, and for inviting us. And we really enjoyed ourselves.
Thank you so much. We look forward to seeing you all more often.
Yeah,
Okay.
definitely.
Bye.
Bye-bye.
Bye.